Hello, everyone. Welcome. My name is Tatiana, and I work at Rider Public Library. And today we are hosting our second house cafe that is about arthritis, move it or lose it. And I would like you to welcome Dr. Rattan and Jeff Kopp, who are going to be talking today about arthritis. So there will be a presentation in this video, and then there will be a place for questions. So feel free to add any questions into the comments underneath the live streaming video that you have on your screens at the moment. And I am passing it to Dr. Rattan.
Thank you, Tatiana, and thank you everyone for attending tonight. The title of our talk is Arthritis, Move It or Lose It. And the reason that I'm doing this talk, I'll just tell you a little bit about myself. I've been working in the community of Red Deer now as a family physician for the last 33 years. And currently about 2/3 of my practice is family medicine, and about 1/3 of my practice is sport medicine and MSK. And with the MSK part, I work at Central Alberta Orthopedics, and I do a lot of work with patients who have arthritis, in addition to other musculoskeletal conditions. And today, the joint that we've chosen to work with is the knee, and that will be our model joint. So I'm going to talk a little bit about arthritis, what it is, how we manage it. And then Jeff Kopp, he works here at the PCN as a kinesiologist, and he's going to talk a little bit about the exercise component of management. So I'm going to turn you over to Jeff right now so he can talk a little bit, and then I will take over again.
Hi folks, my name is Jeff Kopp, and I am a kinesiologist and recreation therapist with the PCN, and I'll be sharing with you folks a little bit about the literature and research that's been done in accordance to exercise and arthritis. And I'll thank you for having us, and I'll turn you back over to the good doctor, and he's going to start our presentation.
Okay, thank you, Jeff. So hopefully everyone can hear me. So let's see if I can. Okay, so what is arthritis? So basically, arthritis represents an inflammation of the joints of the body. And the classic symptoms that people will get with arthritis is joint pain, stiffness with swelling, and this will lead to decreased function. So some of the symptoms or the findings that you may have if you have arthritis is your joint may be swollen, it might be warm, it might be red, it'll hurt when you try to move it, and you'll find that the movement isn't quite as good as it used to be. There are a variety of types of arthritis. The most common type is osteoarthritis, which is wear and tear. And by far, that is the commonest type of arthritis you'll see. The reasons for why people get that are quite varied. Part of it can be genetics. Part of it can be age. As we age, we tend to get arthritic joints. Part of it can be if you've had a joint injury, that can predispose you to develop arthritis later on. Part of it can be if you have an elevated BMI. If you're too heavy, there's too much pressure through a joint, and that can also help to predispose you to developing arthritis. The other thing we find is gender. Often women will tend to get arthritis of the hips and knees at a much higher rate than men. And that doesn't seem fair, but I'm not sure why that is exactly. The other thing to know is that osteoarthritis, as I mentioned, is the most common form of arthritis, but there are other forms that we see. There are inflammatory arthropathies, such as rheumatoid arthritis, psoriatic arthritis, some seronegative arthropathies. There are infectious causes of arthritis too. You can have a virus that can predispose you to develop an arthritis. You can even get a bacterial infection in your joint, which then can turn into an arthritis. So as I said, we are going to talk about the knee joint as an example. So here we are with a normal knee, and the front on the left side here, this says anterior view. So that's the view you see when you're looking through the front of the joint. The posterior view is through the back of the joint. Oh, okay. Okay, we're having a little technical problem here, so we're going to see if we can get our slideshow working. So maybe resume it. Okay.
It's like in the screen share that's not working. Maybe.
So as we are sorting out our technical difficulty here, I'll just describe a little bit about what the joint is then. So the joint is basically made up of, oh, perfect, thank you. So the joint is made up of the bones. So here's our anterior view, which is the front of the knee. And then the posterior view is the back of the knee. And so the joint is made up of the bone. You have the articular surface. And in the knee, we have our menisci, which are basically a fibrocartilage disc, which helps to absorb shock. Then we also have articular surface on the tibia. This is the femur, the top bone. This is the tibia, the bottom bone. Then we also have ligaments on the outside of the knee and ligaments on the inside of the knee. When we look at the back, you can appreciate the ligaments better. You can see how we have our anterior cruciate, our posterior cruciate ligaments. We have our menisci, and then the outside ligaments, which are the lateral collateral and the medial collateral ligament. So the important thing to know about when we're talking about arthritis, we're talking about an erosion or degradation of the articular surface. So one of the two images I want you to think about is that this articular surface is a white glistening surface, which is not rock hard. It's actually quite soft. So if you think about a coconut and you take a coconut and you break it open and you've got the meat inside the coconut. So it's in a coconut that's just right for eating. It's not old and dried up. The flesh is this white material that is spongy, and it has a little bit of consistency to it. And that's kind of what the articular surface is like in your joints. Now, basically, it's this smooth surface, and it's designed to have, it's designed to allow the joint to move smoothly with a very low friction. The other thing that's in the joint is joint fluid. And joint fluid mainly has in it hyaluronic acid, which helps to provide viscosity, which cushions between the bones. And there are also proteoglycans, which help to hold water. And when we have all of that in the joint is nice and healthy, it moves properly, and there's very little grinding or what we call crepitation. So when we go to an arthritic knee, this just depicts how we call it early, moderate, or advanced arthritis. And what ends up happening is that articular surface erodes. So in these pictures, it's a very dramatic representation of the erosion. And in a knee, most of the weight bearing goes through the medial or the inner side, not the outer side. So most of the wear and tear that you'll see is always in that medial compartment first. unless you've had prior trauma, and then you might see it in this lateral compartment. Before you even see these erosions, I'll have you have another image, and that would be of a hard-boiled egg. So if you take a hard-boiled egg and you look at the shell, it's nice and smooth, it's round, it has lots of texture to it, and it's quite strong. But if you tap it with a spoon hard enough, you'll crack it. And what you'll get is little fibrillations. And so when you see that, you'll see that the actual egg is still maintaining its shell, but now you've got these little cracks or fibrillations in it. And so when you have arthritis, that's usually the first thing we will find. And when those fibrillations become really advanced, that's when you'll actually lose little pieces of articular cartilage, and you're basically bone on bone. So I'm going to show you some x-rays, and I hope these show up because they're kind of bright. But so here is a left knee and here's a right knee. So this left knee, here's the medial compartment, and you can see how there's the femur, there's the tibia, here's your fibula or the outer bone. So what we're looking at is the joint space. So these are weight-bearing knees where you're standing. So here there's a big joint space, and that usually means that the meniscus is healthy, the articular surface is healthy, because it allows to create a space. Those structures will not show up on an x-ray, so we see instead a dark space. What we see is the bone. On this medial compartment, you can see how the joint space is quite narrowed. So that tells me that the articular surface is eroded away and you're basically losing your joint space. The meniscus is often degenerated. When you look at this side, you can see how it's very severe arthritic changes here. The medial space is almost opened up and the lateral space is collapsed where it's bone on bone. And the other thing you see is how there's a deformity. Here's the femur coming down in this way, and then the lower leg now is shifted out to the outside. Whereas on this one, you can see it's more of a straight line. So when you start to see changes like that, that's pretty advanced arthritis, and it's going to create major problems. The joint is deformed. There's lots of soft tissue swelling around it. On this one, it's more, what we would probably call early to moderate changes. There's not as much deformity to the joint. You're also getting some spurs forming on the outside. When we look at a lateral view, you can see how tremendous amount of spurring forming above the kneecap, lots of spurring along the femur, lots of spurring in the back. And then again, on the tibial compartment, you can see how we're basically bone on bone. So how do we manage it? So when I'm looking at arthritis, I like to think about it as a pyramid of care. And at the very top of our pyramid is surgery. And there's a lot of different surgeries that we can do for arthritis of the knee. The first thing that was done quite a few years ago and still is done in selective cases is just a joint debris mod, where you go in and do an arthroscopy, you stick different instruments into the knee, clean up the spurs, remove some of the debris, perhaps remove any degenerative parts of the cartilage that are there. Or you can do a tibial osteotomy. So if we go back to this view here, this person, if they had medial compartment arthritis where it was just bone on bone, but the lateral compartment was good, the patellofemoral compartment was good, sometimes we do an osteotomy down here to just sort of open it up, and then that creates space on the medial compartment. And sometimes that will buy people up to 10 years before they have to have a total joint replacement, which is the ultimate surgery. At the bottom of the pyramid is lifestyle changes. And the lifestyle changes are the things that Jeff will talk about in his talk. But the main two things that seem to make the biggest difference to people for comfort in an arthritic knee is losing weight and exercising the joint. So keeping the joint mobile, keeping the muscles around the joint strong. And the more of that you can do on a regular basis, the more comfortable you'll be and the more function you'll have. So again, lifestyle changes, mobility to the joint, keeping it moving, keeping the muscles around the joint as strong as possible, and optimizing our weight. It's been said that you can actually, for every extra pound of weight that you're carrying, you almost have 4 pounds going through the joint. And so over time, that really can create a problem. So medications. So with this pyramid of care, what we're doing is it's an incremental stepwise approach from lifestyle changes all the way to the top. And all the things that I'm going to talk about in the middle here are designed to help you keep doing your lifestyle changes, okay? So medications. Over the counter, Tylenol is a very good medication. It helps to get rid of the pain. The dosing of it, you have to be careful. The maximum dose of Tylenol is usually 4 grams per day. In people who are a little older or people who have diminished kidney function, you can't use that amount. So you need to talk to your doctor or pharmacist to figure out what's the safest dose to use. The other over-the-counter medication that works well is things like Advil or Aleve. And often I'll prescribe it on an as-needed basis or on a regular basis. And again, the things to worry about with Advil or Aleve is that sometimes they can affect your blood pressure. And again, sometimes it can affect your kidney function. So again, if you're starting down the road of medications, very important to continually check in with your physician or with your pharmacist. If these are not effective, then we can prescribe medications. The medications I like to use a lot of are the non-steroidal anti-inflammatories. And these basically are what Advil and Aleve are, but they're drugs that are a little stronger, higher concentrations, a little easier to use because you can use them once a day or twice a day as opposed to multiple times a day. Again, you have to monitor these to make sure that they're not affecting you poorly. If you do have stomach upset or stomach issues with the traditional non-steroidals, we have Cox-2 inhibitors, and the prototype there is a drug called Celebrex. So for people who can't tolerate other anti-inflammatories like, for example, Voltaren or naproxen, often Celebrex works. Again, you have to be careful. And sometimes we even add agents like proton pump inhibitors, Losec, I spelled it wrong, or Pantaloc, in addition to these drugs to just protect your stomach to make sure that we don't have any issues. If we exhaust our medications and they're not working well, there's other adjuncts that we can use. In addition to medications, sometimes bracing is very helpful. And usually the bracing works best if you have a medial or inside joint arthritis, and we would use a custom-made unloader knee brace. And lots of people will use that for day-to-day activity, for work, for sports, and it can make a huge difference to their comfort while they're wearing the brace. It doesn't change anything. It's more like eyeglasses. It improves function, but it doesn't change what's going on. The other thing I do an awful lot of in my practice is injectables. And so steroids are often very useful as a first-line agent, especially if there's a lot of swelling in the joint. If the joint is hot, swollen, then the first time I give a person a steroid injection, it can often give relief for anywhere from 8 weeks all the way up to 16 weeks. But unfortunately, it's sort of one of those things that has diminishing returns. The first shot is fantastic. People always come back and say, wow, that was great. Can I have another one? The second time you do it, it usually lasts about half that length. And by the time you're on the 3rd or 4th steroid shot, you're lucky to get perhaps 2 weeks of benefit. So we usually use those early on in moderate arthritis if there's a joint effusion, and I combine them with some of these synthetic agents like hyaluronic acid, or we use steroids as a temporary measure when you're almost ready for your knee joint replacement to try and keep you comfortable until you have the surgery. The synthetics that I like to use a lot of are hyaluronic acid. As I mentioned to you before, hyaluronic acid is found in your knee joint naturally, and it's an agent that allows for cushioning. In the beginning, when I first started practicing, we used chicken protein as our hyaluronic acid sources. Now we use recombinant DNA, so it's made from bacteria, so it has no animal protein in it. And the ones that we're using mostly are very highly cross-linked, and they have a high molecular weight. So they actually will stay in your joint for up to 9 months to 12 months. And most people will get a benefit from it for probably anywhere from 3 to 9 months. It sometimes does take a few weeks to kick in, but when you combine it with a steroid, then you can get a positive effect usually within a week. A natural product we sometimes are using now is PRP, and that's basically platelet-enriched plasma. So at our orthopedic clinic, what I do there is I would have my nurse draw blood out of your arm. We put it into a machine, spin it out, separate the cells from the plasma, and then we have a way of incorporating platelets into the plasma, and then I inject that into your joint. I find it's mostly useful in early arthritis, in people who are very active, who really want to keep going, do their sports, but they have some limitations from their arthritis. The PRP can be very beneficial to keep them going. Often you need 2 injections. And the problem with both the hyaluronic acid and PRP is the cost. They're both quite expensive, and most plans don't cover them. So PRP, I use it more for early or milder arthritis. Hyaluronic acid, I'll use it more for the moderate to severe. And once it's really severe, really the only thing left is steroids. Stem cells, it's still a research tool. There's been a lot of talk about it, especially in the States. There was one clinic in Alberta who was doing stem cell injections for arthritis, but they've been told by Health Canada to stop doing it because there just isn't enough research. Stem cells we use in medicine, especially in things like, for example, leukemia, where we can do a stem cell transplant and we can cure or even delay the progression of leukemias. But for arthritis, the research just isn't there yet. This is my last slide, and I've put down cycling because it's my favorite sport. But also cycling is one of the perfect sports for knee arthritis. I've had knee arthritis for at least 15 years. It allows me to do exercise at a very high level without loading my joint. It keeps my joint moving, keeps my muscles strong, and it works well. So I'm going to now turn you over to Jeff, who's going to talk to us a little bit about the benefits of arthritis and perhaps how to do arthritis or how to do exercise for managing arthritis. Jeff?
Thank you, Dr. Rattan. I liked how Dr. Rattan ended with the cycling part, because that is one way to reduce the weight that's put through the knee, because that's our model joint here tonight. It's a great way to keep the joint mobile and keep your strength maintained. I'm going to go a little bit further into the types of exercise, the benefits of the exercise you're doing, and explain some more things with the exercise. So, as Dr. Rattan had mentioned, the most common risk factors for arthritis of the joints, mostly with the knees and the hips, is a previous injury, and the big one is obesity. So how can we delay the onset of those things progressing, and how can we keep our joints healthy? So the benefits of exercise with arthritis are documented and very beneficial. So strength, the benefits are you strengthen the muscles around your joints. So if we are talking about the knee, we're thinking about our quadricep muscles, which are our thigh muscles, And those are the ones we want to keep strong. And actually what has been documented is those are the first muscles to be affected when the arthritis is taking place on our body, especially our knees, obviously, is those muscles become very weak, and that's when people have problems straightening their legs. So you want to keep those muscles strong and increase their strength to keep our ability to move that knee joint. As well as exercise helps you maintain bone strength. So weight-bearing exercises are great. That's what helps keeps our bone density. Exercise also gives you more energy to get you through the day, because we know just lagging around the house, going from sitting to standing plays us out a little more. The more exercise we get energy in return because we're stronger. Exercise also makes it easier to get a good night's sleep because we're tired. Also, exercise helps you control your weight. So we know if the more sedentary we become or more inactive we are, the more we're putting on those pounds. When you're able to exercise and be more active, it's a better way to keep the weight off or to get it off. It enhances your quality of life because you're stronger and you're able to move around and still do those activities you're able to do before. As well as exercising with arthritis helps improve your balance. Okay. Now a little more about the talk on exercise. So people are thinking, well, when I don't move, I don't have pain. Well, that is true because you're not moving, but the lack of exercises, which is having you move, actually can make your joints even more painful and stiff. So in part, better to keep moving. It's the analogy, move it or lose it. So you got to keep moving, and that's exercising. So, and not exercising, as I've mentioned before, your quadricep muscles become weak. So not exercising weakens those supporting muscles, creating more stress on your joints. As Dr. Rattan had mentioned, you have decreased space in those joints, you're more bone on bone, and that's having those supporting muscles strong. It doesn't increase the space in the joints, but it helps not put so much pressure on both bones involved in that. So when you are starting, a common example for strengthening are normal body weight exercises as well as weight training. This is an example of strengthening exercises that can help you maintain the strength you already have, as well as it helps increase your muscle strength. And having strong muscles, so we know that walking increases our cardiovascular, but it's better for endurance. But being stronger in the legs helps us walk up and down the stairs longer, or keeps us able to walk the stairs longer, which is a very good thing. We're able to stay more independent that way. Sorry, I'm just going through my slide here. So when you're starting a strength training program, there's no right or wrong reason on how many days a week or how often you should be doing it. But the gold standard is you want to be exercising at least 2 days a week. 1 day is a good way to get your body moving. It's okay, I need to do this. At least doing it one more day, your body knows, okay, I'm getting some benefits from this. It remembers what you did the first day. When I'm prescribing exercise for people, usually what I like to do and what the literature supports is a 3-day-a-week program. And what I like to do when I'm working with people is prescribing a full body workout that people do 3 times a week. And depending on their limitations from their arthritis, I prescribe extra exercise to help strengthen those muscles that are needed to keep independent longer. All right, so I've been talking about strength training. as well as we need to focus on low impact aerobic exercises, which are walking, bicycling, like Dr. Rattan had mentioned, as well as swimming and using the elliptical machines. So what that does is it helps us, our body, get into that caloric burning state, as well as doing those types of exercises that I mentioned help decrease the impact on the knees. So bicycling, your knees aren't banging like they were if they're running. There's not a lot of force. Bicycling is a better motion for that. Swimming, depends on how severe your arthritis is a good exercise to be doing. It helps keep us fit. And elliptical machines, same sort of thing. Now, people always think, well, how long, how much? What I do and what literature there as well supports is people need to be active 150 minutes a week. So if you're thinking about a Monday to Friday week, it's 30 minutes, 5 days a week. And if pain's limiting you from doing 30 minutes at once, you can break that down into 3 10-minute segments a day. Or if you're dividing it into a 7-day week, it's 20-25 minutes a day. All right. And that is low intensity, low to moderate intensity aerobic activity. So it's where you are moving fast, hard enough where you can still maintain a conversation. That's a good way to landmark how hard you're working. And so by doing aerobic activity, the benefits outweigh the cons. So you want to be doing aerobic activity any day you can, every day as you can. Strength training is better to do up to 3 to 4 times a week, having a day of rest in between the muscles that you work. Okay. Now, I have been talking a lot about specific prescribed exercising, but the fact is a lot of people they don't like being in a gym, they don't have the exercise equipment, they don't want to spend the time, they don't have interest. Well, the point is, I had mentioned before, it's move it or lose it. So any movement, no matter what type of movement you do a day, counts. Okay, so if it's doing your gardening, as we know right now, we shovel snow, walking the dog is a good companion to go walking with. Doing walks are great, using the pool, gardening, shoveling snow, any household activity helps keep you moving as well. So the other beneficial activities that have come up as well are body awareness exercises, such as gentle forms of yoga or even Tai Chi can improve your balance. Another big thing with helping improve your balance would be helping to strengthen your core as well. And by improving your balance, you're preventing falls, you improve your posture and coordination, and you promote relaxation. Okay. So the previous slide that Dr. Rattan had up was exercise tips. I just want to make sure I'm going in the right order. Yeah. Those are just some things to be key on when you are starting an exercise program and you want to manage the pain you're having from your arthritis and to make it easier to do. So the first thing is keep the impact low. So jogging, not a good thing to be doing if you have arthritic knees. The walking part is the better thing. A stationary or recumbent bike, or exercise in the water. You could run or walk in the water, and that's actually one of the most promoted ways of being active I do with people is getting them into the pool. It also helps control your temperature, your body's temperature, which helps not take the swelling away, but it's not as pronounced. As well as we know when our joints are all stiff and hard to move when we first get up in the morning, we want to apply some heat to get the blood flowing into those joints, and it finds it easier to move. And we want to move gently. So move your joints gently to warm up, and then you can start increasing your range of motion after a minimum of 5 minutes. Okay. And you want to move slowly. Any sharp, jerky, sudden movements are going to be more painful on those joints, and we want to reduce as much pain as we can. And if you are sore, you want to prevent that onset of soreness. Putting ice on your joints afterwards is a good thing. You can, on the slide, it says up to 20 minutes. That is a good start. You could even start with, 20 minutes would be good. Sorry, I'm not gonna disagree with what I'm putting down. Okay, and then on the last slide that was the recommendations. So when you're doing exercises, I really liked how Dr. Rattan had mentioned that he really enjoys biking. That is a huge thing to keep you going, and it's non-weight bearing. All your movement comes around the joint, but it's non-weight bearing, and it's using the larger muscles of your legs. You want to, as I mentioned earlier, strengthen your quads. And I was thinking I could demonstrate some exercises, but I'm a hands-on type of person. I'd rather meet with people and show them what they could be doing. I find it's more effective and more beneficial for everyone. Oh, I probably just jumped up some more business. As well as core strengthening to enhance your balance. Okay. And as I mentioned earlier, I individualize every exercise program to each person I work with, and I would do that for anybody that comes in and sees me. Oh, our last slide, I think, is going to be our contact information for the PCN. Thank you, Dr. Rattan. So what you can do is just call our 403-314-3297 number, and that'll put you through to one of the schedulers. And all you need to do is self-refer yourself to get in to see me. And I do an assessment with you to find out more about you and where your aches and pains are. And then we set an appointment to meet face-to-face, and we actually assess your movement. Or you can reach, you can reach out to your family doctors. We had one sitting here with us tonight. And now I believe if Dr. Rattan is ready, we have time for questions, unless he wanted to add anything first.
Yes, thank you, Jeff. That was very thorough and very enlightening. Yeah, the only comments I would have to add then is, obviously, when you're first having problems with your joints, it's good to see your family doctor, talk to them. If they feel that you need some specialized care, then they would refer you on to myself or one of my colleagues at Central Alberta Orthopedics. They would also be able to refer you to the PCN to see Jeff. But like Jeff said, he can also see you on direct referral. So at this point, then, we'd like to open up the session for any questions that people would have. So Tatiana, are you still on?
I was reading the chat list, Dr. Rattan. We had a couple comments. Just Diana had asked how to get in contact if she wanted to review options. Contacting the PCN or directly or your family doctor is a great way to get in to see myself, so I can see you, or Dr. Rattan can see you to find out what more options you have. As well as Marion had a good comment on when I was saying use it or lose it, but exactly, we can't overdo it. In that sense, pain is our friend. By You know, if you get the pain, that's when you need to take a step back and allow that joint some time to relax and ease itself.
So,
Okay, unless there's any other comments or questions, then we'll wrap up this session. Thank you, Jeff, for co-hosting this session with me. And thank you, Tatiana and the Red Deer Public Library for collaborating with our PCN with our Health Cafe.